Welcome to another episode of Dr. Doctor, the award-winning radio show and podcast featuring your physician hosts, Dr. Tom McGovern
and Dr. Andrew Mullally, where we and our guests discuss relevant and health-related topics from an authentically Catholic perspective. Dr. Doctor is brought to you in part by the generous underwriting of CMF Curo. Learn more at mycatholichealthcare.org and live your Catholic faith in your healthcare with CMF Curo.
Today, our guest will be heard across the EWTN Global Catholic Radio Network. Joining us will be Dr. Emily Krach, a young family medicine physician in Fort Wayne, Indiana, who's going to reveal the mysteries of how a medical student can transform from her pupa and larva into the chrysalis and become a butterfly of a trained family medicine physician, ready to care for patients. Andrew, how is this topic important for our listeners?
I think it's really important. I think people will be interested to kind of pull the curtain back, see what it's like, just as evidenced by how many TV shows, sitcoms are there about residency training. I mean,
how many, Andrew?
I don't know, an awful lot. I didn't look it up, but several I can think of off the top of my head, and it's because people love this stuff.
Have you ever watched any of them?
I have.
Really? I couldn't.
And it's mostly the ones that are enjoyable. It's when it's funny. And I think, people would be interested what it's like in real life. Some of it's true, but it's not exactly like what you see on TV.
It's not funny every day, is it?
It's not. No, I've been waiting to do this for my whole life. This is what I was built for. Here I am. I finally get to go.
Ooh.
By the way, don't kill anyone. And in other episodes, as we've talked, don't tick anybody off. I always think so much of it, you're working intimately on a team with your coworkers, and there are a lot like sleep-deprived, kind of pregnant wives, except they don't love you. And they made no promise to do so. And so you're constantly trying to tiptoe around people who are sleep-deprived, and you get a day off on the weekend. A lot of people, they'll go work someplace else because you finally got all these loans staring you down. You can finally go make some money, and it's just stressful. It's really stressful. So I think people will enjoy hearing about what it's like.
So Andrew, you grew up as the oldest child of two parents who just happened to be family physicians, both of them. Some children of physicians say that they would never want to be a doctor like their parents, yet you and some of your siblings do want to be. What went right in your family?
I think there's a lot of things, tell you the truth, and it obviously hats off to mom and dad for doing a good job with us. I think hopefully I can do a good job with my kids. But really the thing that was very evident is that there's goods and bads about any work you get into, and the work as a physician lends itself to many uniquely rewarding things where to some extent all jobs you get to help people, but in working as a physician you do get to do that on a very intimate basis. And I know the days that I have really good days, it's usually when you get to help somebody and they're appreciative. Mm-hmm. And a lot of work, even though you're helping people, you don't get that. Gives you a chance to excel, and especially if you want to have a family, it gives you a great opportunity to provide a great living for your family. So it's there's a lot of real blessings, but not to overlook the challenges, but you take them in stride, and you're not blinded thinking that the grass is greener. I mean, everybody's got joys and challenges.
Amen to that. And so, Andrew, you said family medicine. Did you know you wanted to be a family physician from day one of, rational thinking, or did you ever consider other specialties?
I knew I wasn't interested in subspecialties.
Oh.
All these guys, I got a guy I graduated high school with, and he's still in residency. He's going to turn 40 soon, I think. And he's like some super special PhD, MD, interventional radiology dude.
Oh,
I can't even imagine. Student. Yeah, I mean, I'm sure there's people who like that. I knew I was like, I just want to get out as soon as possible, care for people, already start a family of my own. I was really tempted to go for general surgery because I think the day-to-day work was even a little bit more fun. But some of those surgeries, I stand in there, my back would hurt at the end of the day, and somebody needs an appy. A lot of times you're getting up at 2 a.m. to go in, and when I was picking this, I already had one kid and one on the way, and talking to my wife, we said, it'd be nice to not have the call burden. So here I am in family medicine, and I love it. I really do.
Oh, well, that's great. So over the past 5 years, the number of family medicine physicians has increased about 50%. So now there's almost 5,000 new positions a year. That's 14%, 1/7 of all available post-medical school residency training positions spread among 741 programs. So what do you think about this increase and the fact that now 1/3 of new residents in family medicine are U.S. trained MDs, 1/3 are U.S. trained DOs, and 1/3 are international graduates.
Yeah, I think everybody talks about the doctor shortage, and really that hits primary care the hardest. We've got more specialists than we need. A lot of times specialists have to move to certain big cities to get enough work. We don't have enough primary care. And really, in a lot of ways, it's kind of a hard sell getting a lot of people to go into family medicine, because to talk to the insurance companies and to talk to the government, our job is to make people healthy. And that's a big burden because a lot of people don't want to be healthy. And they don't want to be healthy in the way that the government wants them to. And so that leads to a lot of paperwork, a lot of stress, a lot of burnout. My antidote is to try and care for the patient in the way they want, in the way that I can. And that leads to not coercing people to do things. And it's a lot happier way to practice medicine than if somebody, doesn't want to take the COVID shot and the feds want you to, and you've got to check the box or not check the box, or the same thing for a colonoscopy or anything. It'll eat you alive. So I can understand why it's a hard sell, but that's also where the need is. So I think there's a lot of opportunity for people who want to practice family medicine. You can do it.
So it's a good thing that the residency spots are increasing.
Well, and I think family docs are the cheapest to train, too. They're the shortest. So medical education's always been funded in part by Medicare.
Right.
And that's dried up. So the cheapest doctors to make are family doctors.
Right, because it's 3 years after
That's right.
medical school. And what else is 3 years? General internal medicine and general pediatrics.
That's about it. Everything else, you get into these longer programs, and it's just and we probably don't need more brain surgeons. We need more family docs.
Amen. Well, before we get to our stunning interview today, we have our medical trivia question. And the category is common reasons to see a primary care physician.
I liked this one. I didn't get it right. I didn't.
Oh, my.
I don't want to spoil it.
Okay, please don't. I appreciate that. Your prefrontal cortex is operating at high level today. Okay, based on a study by Finley and others called What Are the Most Common Conditions in Primary Care? Systematic Review, that was published in the Canadian Family Physician 4 years ago, which of the following was the most common patient-reported symptom for which they sought a family physician's care? Was it A, I have a rash, B, my throat is sore, C, I got this cough, D, my back hurts, or E, my abdomen hurts, or they'll probably say my belly hurts, or my stomach hurts? We'll be back with the answer at the end of the show, but before that, we'll have Emily Krach on the vicissitudes and the fascinating aspects of what the heck residency training does to give us the young physicians we need here on Dr. Doctor. We're back with our interview of Dr. Emily Krach, a doctor of osteopathy, a native of Fort Wayne, Indiana, where we record Dr. Doctor. She got a bachelor's degree in cellular molecular biology at St. Mary's College in Notre Dame, Indiana. She got her DO degree at Marian University College of Osteopathic Medicine in Indianapolis, and she's a graduate of a 2021 of a Midwestern family practice residency program, and she's incredibly active and greatly desired as a member of the Catholic Medical Association since early in medical school. Emily, welcome to Dr. Doctor.
Thanks.
So, Emily, how would you simply explain the difference between medical school training and residency training?
There are definitely a lot of similarities, but a lot of differences. So in medical school, it's basically first learning how to take a history, learning physical exam skills, perfecting those skills. Eventually, later in end of fourth year, get a little taste of what residency is like by doing some audition rotations and sub-internships. But
okay, let's define those.
Yeah.
People probably don't know, what is an audition rotation? What is a sub-internship?
So an audition rotation would be basically looking out for programs that you're interested in going to for residency and working with them for at least 2 to 4 weeks and getting to know the program, but also showing that you know what you're doing and that they should take you on as a resident.
And sub-internship?
A similar type of rotation where you're basically working under an intern, working with a medical team in the hospital, and also basically acting more as a resident, a little bit more advanced than what you'd be doing during a normal rotation as a med student.
So trying to replicate what you will need to do once you graduate from medical school. So kind of, going up that ramp of responsibility. Now, because of COVID, a lot of interviews for medical students who go into residency, they all went online. And in fact, I heard some programs are not even allowing audition rotations. What do you know about this?
Well, I think it's a mistake. I think the Zoom interview approach is not good because, I mean, I wouldn't have known where I wanted to go if I hadn't actually seen with my own eyes the different programs. And you get to know the people there. Family medicine is all about relationships, and it's basically a personality contest, too. So you're just really wanting to know who you're going to be working with, since you spend so much more time working with the residents and faculty members than a lot of times you end up seeing your own family. So you want to be with supportive people who aren't going to leave you in the dark when you're working at night as an intern and your upper level resident is, sleeping or unavailable. You don't want to be in that situation. So
How did you choose family medicine as a specialty? Everybody's usually got kind of a discernment process. What was yours?
yeah, well, I knew I wasn't cut out to be a surgeon. So
I like it.
You've been holding that one in your pocket, Emily.
But I had a lot of great mentors, such as yourself, Andrew, and just other doctors that I really looked up to, that I thought I want to be like them when I grow up, and just really saw how I could incorporate my Catholic faith into the practice of medicine. Some of the specialties, you have to think, oh, what ethical issues do they have to deal with? But I mean, every specialty does. But I thought, wow, at least I could really see myself living out my faith through this specialty.
Yeah, that's really good. Family medicine, and that's kind words you have for me too. Family medicine is really unique with some of the aspects of it. Tell us about, and maybe you're familiar with the idea of the family medicine instead of just the GP. A lot of people talk about the old GP.
Or family practice.
Because
it's still the American Academy of Family, physicians, I guess, AAFP, not family practice.
Tell us about that transition. What's different now than maybe, 50 years ago? Marcus Welby, was he a family doc? Mm-hmm. Yeah. What's the difference?
Yeah, so I think it's all, people think about the same thing, the idea of a primary care specialist. I'm not sure exactly when the term general practitioner went to the wayside, but I know at least in 2003 it was when the family practitioner name was no longer in use, because the American Academy of Family Physicians actually voted to change the name to family medicine, and then for us to be called family physicians.
She's done her homework.
I like it.
Yes, I looked that up ahead of time.
I like it. Well, and I think probably some of that too is the training. So residency is a 3-year training. Tell us about that. How many hours would you say? What's your usual week look like?
It kind of depends, because every month is different. Every week is different. So explaining our schedule to someone who doesn't know anything about residency can be confusing. So
I thought you had Tuesday afternoons off.
Yeah, exactly. So basically you can't really plan ahead for anything. So, but a lot, it would depend. Some months would be very involved months in the hospital. Some would be more outpatient, a little bit easier going. But we would work at least 5 to 6 days a week, usually never less than that. Even for the lighter months that were more outpatient rotations, we would still sometimes have to work on the weekend and work 6 days a week, just because of having our call schedule, where basically the intern and then a second or third year resident would be working a night shift in the hospital to relieve our day teams when they were finished for the day. So
how many hours were you allowed to work in a row? How many hours were you allowed to work a week, or average per week?
Yeah, so the hourly limit is 80 hours per week, and that's national standard. So the programs want us to follow that. My program was good about making sure we followed that. There were only a handful of weeks that I went a little bit above that, and if it averages out to 80, that's usually considered okay. But most of the time I didn't quite go to that. That was usually more on my inpatient heavy months working on our medicine service.
So were there other months where it was under 80?
Yes, definitely. I would say most months were under 80.
So you said each month is different. So what would be some of the different things a family training to be a family physician would do each of those months?
Yeah, so basically we would have some months just be all on the inpatient medicine service, so admitting patients, rounding on the patients day to day, and there would be a day team and a night team, and then we also had an obstetric service in my program, so there would be a group of residents who would deliver babies during the day and go to an obstetric clinic 2 or 3 days a week to manage the patients in an outpatient clinic, and then then a night team would come in and relieve them. And then we would also have other basically specialty rotations. We would do dermatology, we would do ear, nose, and throat. I did several surgery rotations and many other specialty rotations, but we would also have clinic interspersed throughout the...
So how did those specialty rotations help you to be better in the exam room with your patients?
So a lot of that is to know when to refer patients for us because and what we can treat. So I a lot of times would ask whoever I was working with, whether it be a general surgeon or an ENT doctor, and ask them, what do you think is appropriate for me to take care of on my own? When do you think for sure I should refer to you? And just ask, questions about, okay, I've tried this with a certain patient, and ask for their advice on what I could have done differently.
That's really good. Yeah, it's one of those things that I think probably a lot of specialty training after you get out of the intern year is very different than family medicine, because throughout the whole time you're exposed to such a wide variety. You might go from a surgical one to pathology to delivering babies, and it's kind of the joys of family medicine. When you have medical students that you give advice to, what are some of the pearls of wisdom that you might give to them if they're trying to pick a residency?
Yeah, I would say they need to definitely respect the program director and feel that he or she would support them in if any ethical issues were to arise, or if any uncomfortable circumstances were to arise.
So here's a question I get often from medical students. Should I tell the people I'm interviewing with that there are some things I will not participate in? What would you tell them?
I would tell them that they should feel comfortable doing that. And I didn't have any problem when I was interviewing. I always usually waited till the very end of the interview in case things were to get awkward. But I would always wait till the end, and usually just with the program director, because that's the voice that matters the most in the end, and they call the final shots for everything. So I would always ask them if they had ever had any residents who didn't prescribe contraception or participate in things like tubal ligations or abortions. And at least most of the interviews I did were in Indiana, and they almost every program that I went to, they said, "Oh yeah, well, we've had residents like you before." And then I went to a couple other places out of state, but most of the places said, "Yeah, we would be comfortable with you," or a few said we hadn't ever had a resident like you, but we'd be willing to let you come.
Probably because they really liked you.
Exactly. And that's, I think, emotional intelligence there, first to get them a positive image of you to make it hard for them to say no.
Yeah. And I think, too, it's different in family medicine definitely than OBGYN. I don't think that's the same experience for them. I think family doctors tend to be more charitable and for people who practice differently.
What? Chris isn't even here to defend the poor OBs. I'm not sure he would defend them.
I don't think he would.
Family doctors are, that is one of the things that we try to be, right?
Well, that's why I was initially interested in family medicine, and I realized it later. It's because I liked family doctors. They were people that I'd want to hang out with.
Yeah, that is a very good thing. One of the questions people get a lot is just we kind of talked in the intro about how intense residency training can be and sometimes stressful. What was the hardest part of adjusting to residency training from med school? Did you find it hard to adjust, or was it easier in some ways?
I think it was definitely a tough transition just because of the significantly longer work hours, and then also just everything mattered so much more. So just realizing, oh, wow, I could unintentionally harm a patient because I'm actually the one making decisions now, and that you don't want to be the resident who appears foolish because you didn't know the right thing to do, and you think, well, should I be asking all these questions, or are they going to think I don't know anything? And
right. So there's a lot more. What Tom mentioned, emotional intelligence. A lot more of your grade is based on, just getting along on the team and being an effective member. In residency, you have the board exams, but you don't have regular tests like in med school too, right?
Right. We did, though, have a yearly in-training exam, so actually right around October. Yep. So now everyone's studying in family medicine right now. So
ours was always in April in dermatology.
Oh, nice.
Every year, yes.
Yeah, that's man. I'm glad that I'm not doing any more of those.
So, what was the best part of being a resident as compared to a medical student?
I think definitely I felt more of a sense of purpose in residency
Yes.
because I was actually overcoming some of the initial fear, which I don't think ever truly goes away, of making decisions, because you think back, oh, wow, I should have done that with a patient, or I could have done this. And as I grew up through residency, that I think, and became, more confident, than that, that really definitely gives you a greater sense of purpose, rather than medical school, where it kind of just seems like, okay, I'm paying to do this, and paying to be here for long hours. And
Tell us a little bit about how you had mentioned each month there's maybe a different rotation. Year to year, how did residency change as far as responsibilities and things like that?
Yeah, so basically the first year, intern year, kind of the most intense year, you're basically the worker bee of the program. So
a drone.
You are the one going to admit the patients and first one to see, and even especially in the beginning, though, you're usually heavily supervised. But that's why the joke of everyone saying don't go to the hospital during the month of July, because it's all the new interns that are admitting the patients, and they don't know what they're doing. So you start off admitting the patients, and then usually the intern works with a second or third year resident, and they will talk about the patient, and then talk about what they want to do for the plan, what orders they want to put in the electronic medical records, and kind of just discuss what to do. And then the upper level resident, the second or third year, advises them, teaches them, and then of course later they'll discuss everything with the attending. But
did you feel like, it sounds like the majority of experience is concentrated really in that first year, getting you competent? Did you feel like that was the case for you, or do you pick up on different things the further you get into training?
Yeah, I mean, I think definitely the most intense learning does happen during the first year, at least at our program. I think and not every program does it this way, but I kind of appreciated being almost thrown into the fire, because I think I learn the best that way. I think a lot of people in medicine learn that way. Just you learn by doing, and I think I learned a lot more during the first year than I did during my third and fourth year medical school rotations, because just because I was the one having to make the decisions and trying to do a good job so that the patients had good outcomes.
Did you feel like the work you were doing translated to work you're doing after graduation?
I think definitely, even though now I'm retired from hospital medicine and retired from obstetrics, I do appreciate my education in those areas, and I think that's definitely made me a better outpatient doctor, which I prefer the outpatient setting anyways. So I feel like now I have more, confidence in knowing, okay, should I send this patient to the ER? Right.
And there's some outpatient training in residency too, right? Tell us about that.
Yes. So basically we have our own continuity clinic. So every resident has their own panel of patients, and they start us off really small. So we have only see 3 or 4 patients a day, and that's if all your patients show up to their appointments. So it could be one or it could be none some days. And then you basically see the patient and then report back to one of our staff doctors in our clinic. So basically they'd be all huddled in a room together, and then we'd have to go to the room where all they're waiting for us and talk about our patient experience, or what we were treating the patient for, and basically our plan of what we want to do for their care. And then they would tell us whether, if they thought we should do something differently, and teach us about the patient. And
did you have to get approval for every single patient you saw in residency before you could finish the visit? In other words, did you have to sign it out with a senior physician?
Well, for sure during the first year. So every single patient for the first 6 months not only had to be staffed with a supervising doctor, but they also had to come talk with the patient as well.
Wow.
And then the second 6 months, or the later in intern year, then I had to still staff every patient, but they didn't still have to go talk with the patient. But if the patient had Medicare, then they still were required to go talk with the patient as well. And then during second and third year, as long as you we applied for our full medical license.
Oh, true.
Yeah.
Because you can't get your license until you have a year post-medical school under your belt.
Right. Yeah. So basically everyone who had finally gone through all the paperwork and gotten their official medical license, then we didn't have to staff any patient unless they had Medicare. So some of the residents would never staff anything. I didn't feel that confident. So if there was something that I had not experienced before, I would always go and talk with the staff doctor about what my thoughts were about the patient and wanted, genuine advice and learning from them.
How often would the staff doctors maybe shoot you down or redirect? Is that something that was a common way of learning, or was it more personality? I know there's a lot of things in medicine that there's a lot of ways to do the same thing.
Yeah, I definitely encountered situations where I thought, oh yeah, I really wouldn't do it that way. Some of them were a little bit more, I think, they just didn't care not that they didn't care, I guess, but they more just thought, oh, well, if you want to do that, that's fine. I would do it this way. And then others would say, oh, no, you're wrong. You should do it this way. And so there's some of that during residency that sometimes you just have to do what they tell you, and think, oh, wow, I'm not going to do it this way when I'm out in practice. Of course, none of that was for any, if there were an ethical issue involved, I, of course, wouldn't, I guess, acquiesce to their demands, but...
I guess one question before we go to our break, and that is, when we were prepping this, you talked about residents having trigger words.
Yes, and the funniest instance of trigger words I think that I encountered was that a lot of the residents in my program, well, maybe not a lot, probably several of the girls, they did not like the word abstinence. It was a dirty word to them. They hate it. They think it's the worst thing ever. And the reason why is because apparently in the public schools in our county, they still receive education about abstinence, which is kind of uncommon in a lot of parts of the country.
Yes.
But their reason for getting upset is they actually think that the reason why the gonorrhea rates in our county were higher than most other parts of the state were because the school children were taught abstinence. And
so therefore you can get gonorrhea by not touching somebody else. Explain that one to me.
Right. And so,
my goodness.
Yeah. And so when my brother, and during, I think I was the second year resident, he had just started. He didn't know that was a trigger word. So
yikes.
Yeah. So he ended up saying, well, maybe we should teach our patients about abstinence, when one of the other residents said, oh, does anyone have ideas for these safe sex packages we're going to hand out to patients? And he said, well, why don't we teach them about abstinence? And that just, all hell broke loose after that.
Poor Patrick. Noble thing that he was doing. Well, we're going to take a break here and then talk about some more fascinating stories from Emily's residency here on Dr. Doctor.
And we are back on Dr. Doctor today, talking to Dr. Emily Krach about residency, family medicine residency in particular. Emily, you've got some stories that you were going to share with us, really about the radical loyalty to the culture of death that blinds some doctors. And it's kind of sad, but they're instructive stories. So maybe you could share one or two with us.
Sure. Yeah. The first kind of month that I was seeing patients on my own in the clinic kind of was a little eye-opening to, different perspectives that I was kind of expecting, but not, or sometimes surprised that people would have this view, especially in terms of contraception, and kind of thought, okay, well, it makes sense to me. If the person is having problems or major side effects, then you just stop whatever medicine the patient has, especially if it's really affecting their daily life. And so I had a patient pretty early on that had just had a Nexplanon inserted into her arm, which is basically a form of birth control that usually family doctor or OBGYN will insert into the patient, and then it lasts for about 3 years or so before they have to remove it. And this patient was complaining that she had had several months of daily spotting and bleeding, and she knew it was because of the Nexplanon, because she didn't have daily spotting and bleeding for
it's awfully coincidental.
Yes, before that. And so, I talked with her and said, I really agree with you. I think that's the cause. If you want it removed, I'd be happy to do that for you. And I think that's the best solution.
Oh, so that's something you did in clinic?
Well, I first talked with her about removing it, but then I had to go staff with my staff doctor, who said, oh, well, after getting an Nexplanon, a patient can really bleed for up to 6 months, and that's pretty normal. And I just thought, wow.
Was this a woman staff member?
No, it was a man. And he said,
What if you bled for 6 months
exactly.
Yikes,
I couldn't
yeah.
believe that anyone would have vaginal bleeding and normal for 6 months and normal in the same sentence.
Yes.
But
That is wild.
but he actually said that. And so I said, well, actually, the patient really wants it removed. And, he said, well, but these cost over $1,000 to, implant. You should really discourage her from getting it removed. And instead, you should prescribe her oral contraceptive pills to treat the side effect.
To
And
treat-
I thought, so
Oh,
prescribe
my
her another
goodness.
form of birth control to treat the
Gee whiz.
to treat the original birth control. And so, as it turns out, the patient didn't want to be on a second form of birth
course not.
control. And so she then scheduled another visit to get her Nexplanon removed.
And then you
So
taught her natural family planning, right?
I actually didn't see her for the follow-up because she wasn't one of my patients. So I don't know. She was lost to follow-up.
Would have
for me
been a
at
nice
least.
bow on the story, but not.
Yes.
But then you said that you received an email in your second year of residency related to this same drug.
Yeah, so we actually had quite a few patients in our clinic who were very dissatisfied with their Nexplanons, as it turns out. Not surprising to my brother and I, but we, since we expected people to have these side effects and don't prescribe them, not just because of the side effects, of course,
Right.
but it's a big way I think that at least I can approach the topic with people who don't understand why I don't prescribe contraception. I kind of first go from a medical perspective why, and then delve into the ethics with them.
Yeah.
But the clinic director had emailed everyone that apparently all these people or all these women don't like their Nexplanons. They want them removed. And so because it costs so much money, the program's trying to think, well, we're losing all this money basically by buying these Nexplanons, and then the patients are dissatisfied because the residents weren't doing an adequate job of basically informing the patients about the side effects of them.
Yeah, there's a big push in residency, at least that was my experience, to get a certain number of procedures.
Right.
You've got to get your quota, your threshold, what have you. And so I can appreciate how, maybe informed consent can take a back seat.
Yeah, a lot of the residents, they definitely get excited when there's, something, there's something for me to do. And they get excited about inserting Nexplanons apparently. But the clinic director said, well, they have to go through a more rigorous authorization process basically, or approval process for, in order for them to.
How much did
prescribe
the
this.
Nexplanon insertions decrease after they started that? Any idea?
I mean, I don't know exact numbers, but they definitely, I think, decreased pretty significantly because I didn't at least hear of more of my fellow residents having as many patient visits, with that being the reason for visit. So
Yeah, it's kind of hard, I think, for a lot of folks outside of medicine to appreciate, but the kind of, I'm not going to say standard of care because it's not all that formal, but really the expectation and the goal is if someone is 13 years or older, they need to be on birth control unless they want to have a baby right now. And that's the expectation that's put on the doctors, on residents. And when that's not the way you see the world, it probably makes for some struggles trying to explain that to people.
right, definitely there's a lack of education, lack of knowledge about other better treatments, but significant lack of education about natural family planning, especially even in the church. And
How much education did you get in medical school or residency about natural family planning?
I got a little bit more than most, I think, because I went to a Catholic medical school, Marian University. So we did have some lectures in natural family planning and fertility awareness-based methods. But most of what I learned, I had to seek out myself. So I picked certain rotations, or I, got involved with, of course, the Catholic Medical Association, and also Dr. Dwayne's organization, FACTS, so that I could learn more about.
That makes sense. I remember looking at that in my med school gynecology textbook, hundreds of pages, 2 paragraphs on the rhythm method, and 1 paragraph of that too was on other types of natural family planning. And so it's a blind spot in traditional medical education.
Yeah.
Well, you said among your fellow residents that they thought.
Right. They, most of them, I don't think had even heard of the rhythm method. So most of them just had really no idea of what natural family planning actually was. So they just thought they kind of put together natural. They just thought it was someone just living their life as they saw fit and not.
And babies come
Right.
when they may.
Exactly. Yeah. Just nothing involving monitoring of fertility signs. It was just, that person is just living their life naturally.
It is a miracle, but it's not magic.
So a second story dealt with transgender patient requests.
Yeah, so actually when I was interviewing for programs, it didn't really come up much about any program saying, we have opportunities to train in transgender care. I'm sure there were probably some, but not the programs that I was looking at. So, and definitely not at my program. So I did not ever receive any lectures in our didactic sessions about transgender medicine, and none of my directors or anyone really affiliated with the program knows anything about it, nor do they really want to be involved in it, is from what I've gathered. But we did have patients that were wanting to transition, and so some of the residents in my program were treating them in that way, usually the second or third years. And I'm not sure exactly how many patients they were seeing, but I would hear them talk about their patient encounters and how they were starting to help assist these patients in transitioning. And
they staffed these all out, right?
No, they didn't, because they knew that our staff doctors don't know anything about that. And so they were basically, I guess, just kind of going off on their own frontier and doing whatever they saw fit. And so, I even heard a few residents who really didn't want to be involved in it. They would have a follow-up scheduled for prescribing testosterone, for example, to, a woman wanting to become a man. And so the patient or the resident would say, I don't feel comfortable with this. I don't know what to do. And they know they can't go to a staff doctor. So they would just ask the other resident, what do you usually do? And I thought it was interesting that I never got any of those patients put on my schedule, and neither did my brother. And I never told anyone not to put them on my schedule, but I'm assuming that it's probably because they thought, she won't prescribe contraception. She's probably also not going to.
Probably not down with that.
Yeah. So I don't know or maybe it was just by chance, but.
So not only not evidence-based, but not even going to somebody who might even have experience doing it, which in other areas you were unfamiliar with, you would probably always go to staff.
Right. Yeah. And so I think that's just a growing problem, especially for family medicine residents, because it's really becoming very popular. And I think a lot of the programs are now starting to have transgender medicine as a big part of, come to our program, you can learn how to train in this. So I think that's, I think that would be way more difficult now for people going into family medicine and other specialties too, where they're, I don't know if some places will require them to participate or if it's something that they can opt out of.
Wow. Yeah, it always starts as opt out, right?
Yes. It seems like so many students are in this tunnel of training that they're just being pushed along by this wave behind them that they can't stop, and they have to do everything in front of them if they can do it, not necessarily if they should do it. Do you think there's some truth to that people just stop thinking about morals and ethics in medical training? Yeah,
I think that a lot of the residents just say, this is what my mentor or this is what my staff doctor is telling me to do. It must be right. They have more experience than me. That's just, I think it's kind of surface level rationalization. They say, this person, they think, they'll for sure commit suicide if I don't help them transition, not thinking, I could actually maybe help them target what the actual problem is and get to the root of it.
Exactly. And then there was a third story you mentioned that you had a preceptor that wanted you ask the same question of the same patient, the same situation every time.
Oh, yes. So during
seems repetitive.
Yes. So during part of our obstetric service, we go to a federally qualified health center and see all the pregnant ladies there and take care of them throughout their pregnancies. And one of our preceptors expected us every single time, including the first visit, to ask the patient, and what form of birth control do you want?
And these are pregnant patients.
Yes, after.
Congratulations.
Congratulations. Yeah, and what form of birth control do you want afterwards?
The test was positive this morning.
Right. So, and usually, most of the patients, they're not thinking about that. That's not on their mind. They're focused on the here and now. So,
right.
Yeah, which what I would expect them.
Pretty normal.
So, of course, there's always good ways to get around these kinds of things. So usually I would be careful with my phrasing and say, oh, have you thought about children or family planning at all after the pregnancy? Almost, 9 times out of 10, it was always, no, I'm focused on the here and now, basically.
Right.
So
One of the things I struggled with a lot in residency was, for at least where I trained, you needed to get a written consent 30 days prior to a C-section for a lady to get a tubal ligation on Medicaid. And so there was this big rush at about 33 to 36 weeks that you needed to get this thing signed. And the way it was always told to me is, just in case they want it later, just get them to sign it. But this is a surgery consent form. It's not just in case,
Right.
How did you deal with that, or did you run into that at all?
So basically, I always told them I would not be involved in that. So, but of course, there's always another resident who's eager to do something like that, or and eager to go ask the patient. So I never had to do it, and of course I would, if someone pressured me, I would have refused. But I actually did witness people falsify those documents at times, because there are situations where the OBGYN actually performed the tubal ligation when they hadn't signed the document in the proper amount of time.
Yikes.
So,
Oh my.
and I guess, I could have gone after these doctors if I wanted to, prove what I witnessed, but I didn't really feel like I wanted to devote my time to going after them. And I'm sure it happens a lot more frequently, but
I always thought that was the worst informed consent that I ever saw, when people don't speak English and you're trying to get them to sign a tubal ligation after 1 or 2 kids.
right. And a lot of the doctors that I worked with, they would complain that, oh, it's because, they have Medicaid and that's why they have these silly rules. And I thought, well, not realizing that they have these rules because people are going to go after them because specifically because
it's a vulnerable population.
Emily, you were presenting once before an institutional review board, so you can tell listeners what that is, and you had what turned out to be a funny experience.
Yes. So everyone in family medicine is required to do a research project or a quality improvement project, and basically that's the group that we have to present our propose our project to, and they can ask you a bunch of questions and determine if they think that the project is worth pursuing, and they have the ultimate approval.
And that includes an ethical analysis of what you're doing.
Yes. So basically, I had just finished presenting my project, and they said, "Oh, great, that's fine. Go do your project." Well, the next person who went was wanting to do a project that involved implanting Nexplanons right directly after birth in the hospital, and she was trying to get a grant for this, and it was
So this is an Nexplanon that's normally causing 6 months of bleeding in women.
Yes. and not always. Some women will just not ever bleed after all. So you just really don't know who's going to have the problems, but they'll have plenty of other side effects too. So this resident was really excited for her project, but there were several members of the institutional review board who were I think probably in their 60s, and just they'd been lifelong PhD researchers, and they didn't know anything about birth control. So this is maybe one of their first times, I guess, being exposed to it. And I remember one of those individuals, he said, "Oh, well, I read the package insert of the Nexplanon, and I wanted to know, are you sure this is standard of care?" He said, I just can't understand why any woman would want this.
And the resident's response was,
yeah, she said, oh, she was trying to convince him this is perfectly normal, and that, which I guess technically it's normal because a lot of women get it, but yeah, trying to, I guess, convince him that, oh, well, it's not as bad as the package insert claims to be. But he said, yeah, I can't approve this, and basically said, if you can come up with some better reasons, or I guess prove to me that this is, that it really isn't this bad, then you can have the project approved. But the project never got approved, so.
Yikes, man. Now, hearing these things, it's easy to see the juxtaposition between a Catholic student going through this and the secular medical culture. Were there other Catholic residents around you that could kind of support you, or how did I guess, how did they view the intersection of religion and the practice of medicine?
Yeah, well, definitely, I'd say my Catholic support in the program was definitely my brother, but I estimate, I think probably at least a third of the 36 residents in my program came from some sort of Catholic background. So we had a spectrum. So probably most of them were non-practicing, but a lot of them, came from Catholic background. So you'd kind of, expect them to be a little bit more in line with church teaching in their practice. But a lot of them, even the ones that were actively practicing, just kind of see their medical practice as separate from their faith life. So they would more consider, oh, well, the patient isn't Catholic, or, oh, well, I don't want to feel like I'm forcing my beliefs on someone, which it never is. It's us, sharing our faith through the practice of medicine. And
were they supportive at times when you couldn't follow through on some of these requests?
Do you mean the residents?
The other residents, yeah. Did they say, I got your back, or was it more like you're interpreting this incorrectly? I
mean, I think for the most part, the residents were pretty respectful, and I think a lot of them deep down have, a lot of values that they themselves don't want to be involved in. Like I would say most of them really would never want to involve themselves at all with an abortion. They don't necessarily see referral as involvement in it, unfortunately. Mm-hmm. But I mean, I even had a good conversation with one of my residency classmates who was raised Catholic but had fallen away, and he said that although considers himself to be pro-choice, he knows what abortion is, and he doesn't want to ever be a part of it. He just basically wants to, turn a blind eye to it. And I think that's a lot of their opinions, where they themselves don't want to be involved in things like that, but they'll still claim, they'll still be pro-choice.
Well, what's your best advice for students going through med school and residency who want to follow the admonition in the book of James that, pure religion is this, to care for widows and orphans in their distress and keep oneself from being stained by the world?
I mean, I think it's definitely important to be involved in supportive organizations like the Catholic Medical Association, to meet mentors through the CMA, or to also be involved in the FACTS organization to learn about ways that you can defend your faith and also defend the way that you practice medicine. I think that's essential. And I don't think I would have been confident to go to residency had I not been supported by those groups.
Emily, last question. Can a Catholic make it through medical school and residency and survive?
Yes. And I think we're all proof of that, but I don't know.
Amen.
Times are still changing, so you never know. I think that the next great experiment will be the transgender issue. So
yeah, experiment's the key word. Well, thank you for being on the show, Emily. That was really good.
Oh, this was a blast. Maybe we'll have something to talk with you about again, Emily. So thank you.
And we are back with the medical trivia question. And Tom, I'm going to say I have seen all those things, but I got this one wrong.
So, yeah, this is the heart of what Andrew does every day, and maybe it doesn't parallel what he sees here in Fort Wayne. But based on that study, looking at a bunch of studies, a systematic review, what's the number one patient-reported symptom? Not what the doctor codes later, but what's the number one symptom a patient states on seeing a family physician? And so the multiple choice was actually the top 5. I just mixed up the order. Was it a skin rash, a sore throat, a cough, back pain, or abdominal pain and discomfort? Andrew, what did you think it was?
I thought it was a rash.
You thought it was a rash?
Yeah.
And there were other studies I saw where that the coding, a rash was most common, but maybe there were multiple things coded at each visit, and that was not the primary thing they brought up. I don't know. I saw that. But this is the only one that looked at patient-reported complaints,
See, that's
not
good.
coding.
Yeah.
Because you can find a skin diagnosis on every single patient in the world.
And see, I'm always jealous of the specialists a little bit because y'all have it so easy. I'm sorry, the liver's not my specialty. Talk to your family doctor. But I can't say that. And so whenever I'm stuck in there for whatever reason, they're like, oh, and I've got this and this and this. I'm like, I want to help you, but we've only got a limited amount of time. So rashes are part of that.
Oh, yeah. And the thing is, in derm, you'd think it would be easier, but there's so many different things that can be on the skin.
That's true.
They'll just bring up things they wouldn't bring up to you. But anyway, the answer is cough. 19% of people presenting cough was number one. Shortly behind were back pain, abdominal pain. Fourth place was sore throat. And actually, fifth was skin rash at 13%.
Yeah, coughs can be nagging.
So, Andrew, top 3 takeaways.
Well, I would say number one probably was the sentiment she ended on. Emily did a great job describing training and her experience, but if you're somebody who's interested in medicine and you're a person of faith, especially a Catholic, we'd encourage you to do it. We need more of you because we're getting diluted, but you can do it. Number two, I would say, is you've got one of the things that Emily demonstrated so well is she was a whole person before she started medical training. And she demonstrated that she had guns to stick to. A lot of people that I interacted with in training were not that way. And if you don't know what you stand for, you're not going to be able to do it. And I think a lot of people suffer in that way. So my advice would be, if you're going to go into healthcare, know the things that you won't compromise on and why you feel that way.
Amen.
And then number three, Emily touched on it, and I feel this way too, is just the mentorship. You know, throughout training, mentors are so important. And just another little shout out for folks listening to the Novus Medicus. If you're interested in healthcare, especially in becoming a physician, look up Novus Medicus and get in touch with people who can help mentor and support you in that journey.
Yep, those are the young members of the Catholic Medical Association. If you are, or you know somebody who's in medical training and wants to be a Catholic, NovusMedicus.org, and you can connect with live people soon. So thank you for listening to us on another episode of Dr. Doctor. You can find this and all old episodes on our website, drdoctor.org. Just click on Episode Archive at the top, and you can search over 290 episodes by topic or guest.
And we now offer a video version of our podcast. Just click on the link of the YouTube link near the top of the homepage at drdoctor.org. And we're looking for great ideas for episode topics, or even if you have a question, just click where it says Submit a Question.
This is Dr. Tom McGovern.
And Dr. Andrew Mullally, and we're signing off until your next dose of Dr. Doctor.
The views expressed on Dr. Doctor do not necessarily represent those of your co-host. Have a question for our doctors or a topic you'd like to hear about? Call or text your questions to the Holy Cross College text line at 260-436-9598 or fill out the form at drdoctor.org. Follow us on Facebook and Instagram at Dr. Doctor Show and tune in for new episodes every Friday. Plus, find all our past episodes at drdoctor.org.